So just thank you so much for the MPA organizing committee for inviting me to speak. And also want to thank the three presenters on your exciting presentations. So Sanjeev asked me to spend the next few minutes to reflect on the three presentations and reflect on and what I do as well. So maybe before I start, I'll just give you a little bit more context. So I see two of my bosses there. So I'm a family physician. So Lynn's my boss. I'm a family physician, not a psychiatrist, physiatrist, or medieval studies scientist. And I work as a community physician at academic, but community family physician at Toronto East General Hospital. I also work at undergraduate medical education, and my other boss, Jay, is sitting there. And we are launching a very exciting initiative, which is the revamp of our undergraduate medical education pre-clerkship curriculum. And the new foundations curriculum is going to be launched in 2016, August. So I just want to give you some context and you'll understand why and how I reflect on these three presentations. So we heard three presentations that demonstrate huge impact and very creative, and the impact is not just locally, nationally, and also internationally. And since I only have a few minutes left, what I'm going to do is just to focus my thoughts and reflections on two things. For those who know me, you understand my first reflection is on technology. As I spent a lot of time using and delivering and creating technology-related curriculum content. We heard from Andrea Furlan on innovative delivery methods, using OTN and using telemedicine to deliver education. And we heard from Dr. Esplen, Mary Jane, on innovative modality, not just using online learning, but also on if you could dig deeper, it's not just online learning, it's also blended learning, also using e-portfolio, using gaming, and using various strategies to deliver education. So we heard from those two speakers. What excites me the most is actually not about the technology part, but about the introduction piece to the introduction of your presentation, which is both speakers use or clearly articulate and identify an educational gap or curricular gap. And using technology to solve the gap is just secondary to your initiative or to the technology. And as a faculty, I often have clinicians come to me and ask me about, I see this very fascinating tool, or maybe this app, or maybe this game, or we got to have it. We got to use it for undergrad, postgrad, continuing education. And my first approach always is, okay, what exactly is the gap? Because in person, one-on-one, as we heard from Dr. From Sean earlier, is that in person may be even better, and simulation cannot solve everything. So just adopting and using one technology is not going to really help you if you cannot articulate the educational issue. So be it a consistent approach to training professional or delivering guidelines, what we heard from Mary Jane, be it reach to community physicians and building capacity, or be it the changing behavior, those are the particular curriculum gaps or educational gaps that we have to identify first. So I find that more fascinating than the technology side. So, and you may be surprised if you know me. The second part, the second side I want to reflect is not technology, but the pedagogical side, and just want to reflect on David's presentation. And maybe I should also mention that I also want to reflect on the introductory video. What you saw introductory video early on, and there was a family physician, Dr. Ruby Alvey, who was a community family physician. Ruby, I don't know where you are, from Mississauga, and we saw her examining a patient, talking to a patient, listen to her lungs. I don't know what else you did, but you did you communicate with the patients, and that reminds me of what I do in my day job as well, is learning from patients, and which is David's presentation. It reminds me of Maria Malopoulos, Wilson Center scientist and also UME MPA scientist, of her work in adaptive expertise. Is what I do every day maybe I should ground it by saying that I always tell my residents or students that I learned the most in my first year of practice or first 2 year of practice, because I learned from my patients, I listened to my patients, I learned from my mistakes or failure of treatments. Why am I continuing to counsel someone on nutrition with and obesity management without talking about their mental health? Why do I always get so frustrated when someone's A1C is not improving, without thinking how mental health or other conditions, psychosocial issues is really linked, and I can't just focus on one thing. So Maria's work on adaptive expertise really reminds me of how I learn in real life, how I prioritize different comorbidities or issues, how I learn to treat patients holistically and as a whole. And the complexity in real life and the contextual understanding or learning in real life makes me an expert and allow me to have that critical reflexive practice. So my reflection is that bringing your work upstream, downstream, upstream, I guess, to undergraduate medical education and postgrad is extremely important. Reminding myself of, when I was in med school 20 years ago, it was about learning courses after courses, but not really understanding how it works in real life until much later on. And that's why I told my residents that I learned the most in my first year of practice. So I think having that innovation and bringing it upstream is extremely important. And the last thing I want to mention is about the integration of competencies, and that's also work from Maria Malopoulos and sitting next to her, Nikki Woods from Wilson Center. We can continue to be more granular and get our students to learn how to be an expert, how to be an advocate, how to be a communicator. But what we're hearing from all these talks and especially learning from patients is you really have to combine these competencies. You can't be just a good communicator. That's not going to fly. You can't be just an expert, but really about the integration of competencies and treat the patient as a whole, and which aligns quite well with the conference of integrations in education and MPA. So that's my reflection, and so thank you so much for your presentations and allow me to learn and reflect, and look forward to speaking more during the panel discussion.
Maybe I'll start with a question. The D'Souza project, does that include pediatric oncology?
We did have a pediatric educator. We do have some pediatric courses, but there is no national exam in Canada for certification in pediatric care. So all of our national exams are supported by online support group, study groups, and then we give them a mock exam and get them ready for the exam. So we do it for the U.S. pediatric exam. You can get certified in the U.S. through the U.S. has a certification specialty exam in pediatrics, and we have a course for that. We have had some courses. We lost our pediatric educator full-time when the ministry cut us, but we do sometimes we're working with POGO in Ontario, which is the Pediatric Oncology Society.
Thank you. Okay, so if you have a question, we'll bring the mic to you.
We do have a question on Twitter.
Okay, go ahead.
So this is from Karen Leslie. Is she nearby? She used an acronym. I wasn't quite sure. HCPs? Professionals. Okay. So Karen's question was, she's wondering about any work done with patients who are also healthcare professionals, and if this could inform healthcare professional med psych education. So I think she's directing it to the panel in general and not to any single person. So anyone can answer. So the question again was, she's wondering about any work done with patients who are also healthcare professionals.
So I'm happy to start. I think, it's a great question, and it speaks to, sorry, got me all choked up with that question. It speaks to the role that we play when we're in the room, and what role we're actually playing, and to what extent people are willing to self-disclose. So when you look at the literature, it's a topic that's not really covered. And I think that's in part because we don't create necessarily a safe space to do that. And it's something we really need to think about, because I think, on the mental health side, if you think about the people who come and do that work, a lot of people have, a history of some sort, whether it's their family or an interest. And so, there's a very fine line between what's your professional self and what's your patient self. And let's face it, we're all patients. If you haven't been one, you will be at some point. I can predict that. And so we need to think about how we identify these roles. And when we come into the room, how do we disclose what role we actually what we want to play, and how does that get received? So if I've been a patient advocate for a long time, and then I move into, in a certain sphere, a health professional role, how does that get interpreted, and how do I navigate that? And we haven't done a lot of work to help people do that, and that's part of what we want to do through the competency program.
I know for us, because cancer is relatively common. A number of our educators have had cancer, and they all disclose it. And in our compassion fatigue course, one of the co-educators has had cancer. And we've also had, in the area of mental health, we've had some practitioners disclose and work with in their education when they've had problems with burnout or something and sought help, because we talk a lot about interventions. So we've actually encouraged that, and I think it's because it's also not mental health, but cancer is such a common illness that your educators are you're going to run into them that have had the disease, and they want to be authentic when they teach.
Thank you. Your presentations were outstanding. Very, very inspiring. Each one different. Your initiatives different, but quite related and really quite amazing. Andrea, I wanted to talk to you a little bit more because there were some aspects of the ECHO project that I found really kind of important, and I hope would really inform some of the activities of the MPA. And because it seemed to me that you were taking a bit of a strengths-based approach, right? Like around really trying to help build on the existing expertise or capacity of the primary care groups that you're dealing with. It sounds like there's some peer mentoring going on, and it felt like a very respectful model. So clearly there are going to be gaps, or people wouldn't be signing up for the ECHO project. And we know that probably all clinicians are struggling around issues around chronic pain and substance use and et cetera in our province. But I thought that and I'm going to be a bit biased because I'm a family doc, but I do think that there's a lot, and we're by no means perfect, or these sorts of projects wouldn't be going on, but there's a ton of experience and expertise in primary care around complex comorbidity and taking a patient-centered approach and a family-centered approach. I mean, that's how you do family medicine well. And I just wonder if you have any more comments on that and any advice for the MPA as they move forward based on what you're seeing as really an international expert in an area, but working with primary care providers.
Yes, so I had never worked with primary care so close. I was a specialist living in an ivory tower, UHN, and to tell you the truth, when I signed up to be the paying expert in ECHO, I thought I'm going to teach them, right? I'm going to teach everything that I know and they need to learn. I'm learning 10 times more than I'm teaching from them, because the expertise in the community is great, but there are some things that is happening. Those things are, sometimes they don't know that they know, and you have to reinforce that, no opioids for this patient. Yeah, you're right, but then what? What do you recommend? The other thing is, there are a lot of sharing of where you find resources in a very scarce environment like rural and underserved areas in Ontario. So they have been very creative. They find things on the internet that I never knew existed because they don't have the resources that I have in downtown Toronto. What happens is, one practitioner living in Marathon is learning from another practitioner living in Iroquois Falls. They would never communicate if it was not for this community of practice. And they're sharing, they are talking now to each other, independent of ECHO. So we see that there is a lot of confidence building happening. We see clearly we were doing a lot of pre and post questionnaires and focus groups and interviews and quantitative and qualitative. We see that they are feeling more competent, challenging, they are more confident in saying no to patients, they learn skills, and it's not only because of the ECHO, it's also because of what's happening within the team. So sometimes they sit with a pharmacist and they didn't know, oh, I didn't know you can do this. So now they're collaborating more on their sites. And also, we also do a boot camp. I didn't have time to speak everything that we do, but it's not only the weekly telemedicine sessions. We bring them once every 6 months to Toronto or to a central location where we teach them some skills base that we can't teach over the camera. So I don't know if I answered your question. Yeah.
It's amazing what you can do when you put people together solving a common problem, which is what ECHO is all about through technology. It's amazing. Are there any other questions? Okay, well, I'd like to thank our panelists and for a wonderfully stimulating discussion, each of you, and it was great to hear these new innovative ideas. And I'm going to invite Dr. Songlikam to the podium again to take you through the final part of our program.